Hi everyone, my name is Brianna Johnson. I'm a data science senior and I conducted my research on detecting medical errors in the cancer screening process, specifically focusing on lung cancer screening protocols. About 5.5% of the United States population will be diagnosed with cancer at some point in their life, which results in over 600,000 lives being lost to cancer each year in the US. As a way to combat this, the American Cancer Society recognizes cancer screening if it will help improve longevity after diagnosis. One of these areas that does have screening protocols is lung cancer, which is the leading cause of death above colon, breast, and prostate cancers combined. However, screening protocols currently only consider those who have a history of smoking. In 2008, non-smokers made up just 8% of total lung cancer cases, but in 2020, that number has risen to just about 20%, with no new screening protocols being in place. One of the major reasons why these screening protocols are not in place for non-smokers is because of the risk of radiation. A lung cancer screening results in a yearly low-dose CT scan, and they don't believe that they have certain factors to pinpoint which non-smokers are developing lung cancer to be able to justify screening. So that's the main purpose of this project. So for this project, I was able to obtain access to the National Cancer Institute Cancer Data Access System. They released a study in 2018 that covered over 150,000 participants, and you can see a distribution at the bottom of which categories these participants fell into. So some did have lung cancer, others did not. They also had an array of smoking history. I do want to point out that a non-smoker was classified as someone who has smoked less than 100 cigarettes in their life. So if they smoked once or twice when they were young, they were still grouped into that non-smoker category. And then you can also see a fairly 50-50 split between males and females. However, what we're most focused on for this research is the baseline questionnaire that all participants had to fill out before entering the trial. This questionnaire has information related to their medical history, family history, as well as different environmental factors. So the first thing that we wanted to do was some exploratory data analysis on our data to see what type of distributions we were dealing with in terms of the stages and the types of smoking history. So the first thing that we wanted to do was map out the number of days lived after their cancer diagnosis to see if there's a difference among stages. Naturally, we would predict that there would be, because otherwise, what would be the point of screening if you were diagnosed at stage 1 and stage 4 and had an equal chance of living as long? However, what you can actually see is those with stage 1 did outlive those with stage 3 and stage 4 cancers. Again, we broke this down by smoking status because if non-smokers were outliving smokers, then again, maybe screening protocols wouldn't be necessary. But what we saw was actually the opposite, and a lot of smokers were outliving those who had never smoked before. The last distribution we looked at was age. Right now, screening protocols for smokers are screening yearly from the ages of 55 to 75. So we wanted to see if the data that we had amongst all stages kind of reflected that model. And as you can see, it pretty much did. So again, if we were to make a recommendation for non-smokers, we would probably do it of the same age range between 55 and 75. Going into the methods that are actually used in this project, all the methods do follow machine learning classification algorithms because we are trying to predict that binary outcome of whether or not we believe an individual could have lung cancer. One thing that I do want to point out is we did narrow down this data. So if you can think to 2 slides back when I showed the distribution of those who have lung cancer and those who don't, it was a fairly drastic distribution. We wanted to make this more closely resemble to what the chance of having lung cancer in the United States is, which is about 1 in 15. Specifically, we used 27 different attributes, and they related to that family history, medical history, as well as different environmental factors. These are the methods specifically used. I will go into detail of each one. And then the last thing to point out is that this did follow a 70-30 model. So 70% was being trained, 30% was tested. Getting into the results of the logistic regression, as you can see, there are not 27 attributes here on the left. What I did was the initial logistic regression with all of the attributes, and then from there I narrowed it down to only those based off their p-value that were considered most significant. One thing that I do want to point out here, just because you're going to see that it's a common theme throughout all of these studies, is this emphysema. So this disease had a very significant p-value. It is a disease that's seen that causes lung damage, and therefore there are a lot of individuals who have both lung cancer and emphysema. It's also very common in smokers. So we kind of knew that was going to be a strong predictor. But some other things that were interesting was BMI. We found that a lot of individuals who are overweight were at more risk of developing lung cancer. What I really want to spend some time focusing on here is the confusion matrices. As you can see, I have two. So the first one was set with a prediction threshold of 0.5. So essentially, when we run each of our test observations through this logistic regression, a output is given between 0 and 1. Those that are tending towards 0 or tending towards 1 are kind of grouped in those areas based off that prediction threshold. But as you can see, our true positives was significantly low, only pointing out 9 individuals. So instead, I lower the threshold to 0.15, which you may think is really low. But right now, all smokers between the ages of 55 to 75 are screened yearly, and there's only about a 15% chance that they actually have lung cancer. So that's kind of why I set the threshold to be that value. And again, our true positive rate increased 25 times, which was great. And then I just have our AUC ROC curve. We had a value of about 66.3%, which, it isn't exceptional, but it's not terrible either. So the next thing that we wanted to go into was the CART model. So one of the main reasons why I want to do this model is because it's so easy for a doctor to be able to follow. So if you look here, it's really only 5 levels, 5 simple questions, yes or no, they can ask a patient. So for example, if our patient did have emphysema, it would be a value of 1. So we'd go over to the left at no. And then if they only had less than 1 individual in their family with lung cancer, we would give out a value of 0.23, and they would be subjected to screening. So this is very easy, simple model to follow. Again, our confusion matrix had similar results with about 200 true positives being identified. And our AUC was slightly worse, 64.8%, but 64.8, 66.3, pretty similar. I do just want to show what the original classification regression tree was. Significantly more complicated. If a doctor had to go through each of these questions, it would be much harder. And the accuracy really wasn't all that improved by doing this. It was only about like 1 or 2% better. So you can see when we narrow down to just 5 levels, it's a lot easier. The next thing that I just want to talk about very quickly is the random forest and boosting algorithms. So random forest I want to talk about because I specifically want to point out the error that's seen with the true positives, because I think that might seem really bad or that this model isn't performing well. But the main goal of this is that the medical field believes that there are not certain factors that could pinpoint who had lung cancer. So they would have to subject all of these individuals to excess radiation when they would never have a chance of having lung cancer. So what we want to have is a very low negative error rate, but then our positive error rate can be high because we're making sure that we're not, unnecessarily exposing thousands or millions of individuals to radiation. And then lastly is just this boosting algorithm. Again, we're seeing the common themes of emphysema, BMI coming up. Education I thought was interesting just because we wouldn't naturally predict there'd be a correlation, at least there's no medical reasoning we would, but obviously there could be some other factors at play as to why that's consistently showing up. So just to discuss it a little bit, the important factors that were consistently seen and kind of those that we could use following that 5 question Pruned CART model were the emphysema, having a BMI over 25 or being overweight, a history of bronchitis, as well as a family history of lung cancer, specifically if multiple individuals in your family have lung cancer. And then just comparing through this graph here, the logistic versus the CART model. The accuracies were pretty similar. CART model did a hair better. Again, just talking about that true positive or that sensitivity rate being a little low. But what we're really trying to do is keep that true negative rate as close to 100% as possible. So, although we aren't necessarily screening every non-smoker, we can say that those that we are screening, it's not really a waste. We're not unnecessarily exposing individuals to radiation if they don't have to be. And lastly, I know I'm probably running out of time, but just some further investigations, if this were to be taken into account and incorporated in the medical field, I think it would be interesting to observe what happens with that life expectancy if it does increase for non-smokers with lung cancer. It would also be interesting if we studied screening every 3 years or every 5 years rather than yearly, because if we had that opportunity, we probably had the chance to decrease our specificity so that we could increase sensitivity because it wouldn't be as much radiation exposure. And then naturally, as further developments come out around SARS-CoV-2, the coronavirus, as well as worsening air pollution with all the wildfires on the West Coast, it'll be interesting to see if any of those have long-term impacts on an individual having lung cancer. Are there any questions?
I second Brianna's invitation for questions, please, from the audience and the panelists. We're now in the undergraduate section of the presentation, so the new panelists.
So I saw one question in the chat that I can answer real quickly. So yes, this was taken into account, secondhand smoke. In the very initial studies, one thing that I thought was interesting was looking, and I didn't have enough time to include it, but air pollution in other countries. So specifically countries like China, Indonesia, India that have a lot of factories and a lot of individuals are experiencing secondhand smoke. The problem with incorporating that specifically in this study is that there are also culture differences. So there were vast differences between the amount of males and females that were having lung cancer. But again, it was very, it's not correct for women to be smoking in a lot of those cultures. So it was something considered. For this data specifically, it didn't identify individuals who were exposed to secondhand smoke, so I couldn't include it in the data set, but it was something that I talked about and looked at when I initially started this.
Where did you get your data set from? I'm sorry if I've missed that.
Yeah, of course. It's the National Cancer Institute. So they release every year all of this information. Specifically, it was the Cancer Data Access System, and it crashed my computer how big the file was. It had tons and tons of information related to the treatment, diagnosis of lung cancer, but specifically we're focused on that baseline questionnaire that had a lot of environmental, family, medical history aspects to it.
Does that also encompass vaping, or is this just smoking?
So just smoking, I think one of the main reasonings was because it's looking at individuals who are the age of 55. So vaping isn't really as important. But what was interesting is it did break down how they smoked. So if that was through a pipe, a cigar, just a regular cigarette, we didn't see much disparity in that. And again, we really wanted to focus on factors apart from just smoking that were leading to 20% of the population of lung cancer patients being non-smokers.
Thank you.
Thank you.
Any more questions?
Hi, Brianna. So this is a very nice talk. So I just have a quick question about the data itself. It seems the data is biased because we have so many positive cases, and that is the same for the model. So it seems it more prefer the positive cases too in the prediction. So I'm wondering if you consider any methods to like just to mitigate this issue, balance the data, or just balance the model capability.
Yeah, absolutely. So actually, this is a good slide to have up. So when we first got our data, there were over 150,000 individuals without lung cancer and only about 3,700 with lung cancer. And so when we ran a lot of the models, we were finding that the values that were coming out were just not significant enough to include. And so that's why I think I talked about a little bit. I probably didn't get to talk about too much. So I turned it into a 1 in 15 model. So it was still randomly split, but it was more controlled, and it wanted to be representative. Right now in America, every 1 in 15 individuals has lung cancer. So that's what I made it into. So that way it would kind of mirror what we're seeing between the positives and the negative cases. And then hopefully the regressions would be take some of that bias away.
Thank you. Thank you so much for the comments.
Any other questions, please? We're slowly running out of time. If not, well, let's thank the speaker. I don't see anything in the chat.